Welcome to A&P Live Studio. I'm your host, a registered nurse and anatomy and physiology instructor for healthcare professionals. Today, we're going to explore the really complex pathophysiology of major depressive disorder, and we'll start with a story that might sound all too familiar to many of you out there in clinical practice.
Think about that sentence for a moment. I just don't enjoy anything anymore. It's so simple, but it's also so devastating because it really captures the heart of a condition that affects millions of people. This is the voice of a patient, someone whose entire inner world has been changed. Let's get to know her.
So this is Jane. She's 48, and she was brought into the hospital by a friend who was really worried about her. She recently lost her job, and since then, it's like her world has just shrunk. She's experiencing what we call anhedonia. That's the clinical term for losing pleasure in things you used to love. Along with that, she has this constant low mood, she can't sleep, and she's struggling with intense feelings of worthlessness. These are all signs pointing to something serious going on.
To really get what's happening with Jane, we're going to follow a clear roadmap. We'll start with how the brain is supposed to regulate mood, then we'll dive into what goes wrong in depression, see how that leads to symptoms like Jane's, talk about diagnosis and treatment, and finally, we'll tie it all together to see how the entire body is affected. Okay, let's jump right in. First up, normal mood regulation. When things are working right, our mood is kind of like a beautiful, complex symphony playing inside our brain, conducted by a whole orchestra of electrical and chemical signals.
And the main conductors of this symphony, they're called neurotransmitters. These are the chemical messengers that leap across the tiny gaps between brain cells, called synapses. Now, three of the absolute stars of the show when it comes to mood are serotonin, which is all about our sense of well-being, norepinephrine, which handles alertness and energy, and of course, dopamine, which drives that feeling of reward and motivation.
So in major depressive disorder, or MDD, that beautifully tuned symphony starts to fall apart. The communication breaks down. It becomes dissonant. So let's take a look at what is actually going wrong inside the brain.
You know, for a long time, the go-to explanation for depression was a simple chemical imbalance. But the newest research is actually flipping that idea on its head. It turns out it's not just about having low serotonin. It's more likely that the real problem starts with disruptions in these huge brain networks, these circuits, and that problem then leads to the chemical imbalances as a secondary effect.
So what does a disrupted circuit even look like? Well, in a healthy brain, you've got this nice balanced conversation going on between your logical control center, the prefrontal cortex, and your emotional center, the limbic system. But in depression, that balance is lost. We often see less activity in the control regions, like the dorsolateral prefrontal cortex, and way too much activity in emotional centers like the amygdala, which basically gets stuck on high alert, seeing threats everywhere.
Now, if we zoom in even closer, down to the cellular level, we find a few things going on. First, there's less of a crucial molecule called brain-derived neurotrophic factor, or BDNF. Think of it as fertilizer for your brain cells. Without enough of it, they can't grow and connect properly. Second, the body's main stress response system, the HPA axis, gets stuck in the on position. This chronic stress can then trigger neuroinflammation, a third key problem. And finally, the brain support cells, the glial cells, start acting up, which just adds more fuel to that inflammatory fire. Let's spend a second on that HPA axis, because it's a huge piece of this puzzle. It's our body's central alarm system. Normally, when you face a stressor, your hypothalamus sends a signal, which tells your pituitary gland to send another signal, which tells your adrenal glands to release cortisol, the stress hormone. But then, that cortisol is supposed to circle back and tell the hypothalamus, okay, you can turn off the alarm now. It's a negative feedback loop. In many people with depression, that off switch is broken. The alarm just keeps blaring.
Okay, so we've covered the circuits and the cells. Now for the most important part. How does all this physiology actually explain why our patient, Jane, feels the way she does? Let's connect the dots. This is where it all comes together. Every single one of Jane's symptoms has a physical cause in her brain. That anhedonia, her inability to feel joy, that's tied to an underactive dopamine reward circuit. Those crushing feelings of worthlessness and guilt, that's her prefrontal cortex failing to quiet down that overactive, hypersensitive amygdala. Her trouble thinking and concentrating, that comes from reduced BDNF in key areas for memory and cognition. And her messed up sleep, that's a direct result of that HPA axis alarm bell that never turns off.
And we absolutely have to talk about the potential consequences when this disease is left untreated, because they are tragic. Somewhere between 10 and 15% of people with severe recurrent depression will die by suicide. This isn't a failure of character, it's the terrible final outcome of a progressive physiological illness.
And beyond the risk of suicide,
Untreated depression creates a cascade of other problems. It dramatically increases the risk for other conditions like anxiety and substance use disorders. It actually makes chronic medical illnesses like diabetes and heart disease worse. And of course, it can completely devastate a person's ability to function at work, at home, and in their relationships.
So, knowing how serious this all is, you can see why getting an accurate diagnosis and finding effective treatments that actually target these biological problems is just absolutely critical.
Now, diagnosis isn't just a simple checklist, it's a careful process. It starts with a thorough psychiatric evaluation. But then, and this is so important, we have to rule out physical causes. For instance, an underactive thyroid can look exactly like depression, so running labs like a thyroid panel is essential. Once that's done, we apply the official DSM-5 criteria, which requires at least 5 symptoms for 2 weeks or more.
So how do we treat it? Well, one of the most common tools we have are SSRIs. The way they work is actually pretty elegant. They basically block the little vacuum cleaners, the reuptake pumps, on the neuron that sent the signal. This keeps more serotonin floating around in the synapse for a longer time, giving it a better chance to deliver its message.
A similar type of medication, called an SNRI, does the same thing, but for 2 neurotransmitters instead of 1. It blocks the reuptake of both serotonin and norepinephrine. This dual action can be really helpful for patients whose symptoms include a lot of fatigue and lack of focus, since norepinephrine is so involved in energy and alertness.
But medication is far from the only tool in the toolbox. Psychotherapy, like cognitive behavioral therapy, helps patients rewire those negative thought circuits from the top down. For tougher cases, we have things like transcranial magnetic stimulation, or TMS, which uses magnetic fields to gently stimulate underactive parts of the brain. And there are newer options like ketamine, which works on a totally different neurotransmitter system to promote rapid healing between brain cells. For the most severe cases, electroconvulsive therapy, or ECT, is still one of the most effective treatments we have.
And that brings us to our final big idea, systems integration. I really want you to take this point home with you. The brain is not an island. Depression isn't just a mental illness, it's a systemic illness. What happens in the brain sends ripples throughout the entire body.
Look at how this breaks down. The nervous system is obviously the main player, but that haywire HPA axis, that's an endocrine system problem, and it floods the body with stress hormones. That then triggers the immune system, causing chronic inflammation. And all of that, the stress and the inflammation, puts a huge strain on the cardiovascular system, increasing the long-term risk of heart disease. It's all connected.
So let's just recap that whole journey one last time. We start with a healthy brain with balanced circuits. Then, things like stress, genetics, or inflammation cause disruptions at the cellular and circuit level. That brain dysfunction then shows up as the clinical symptoms we see in our patient Jane. And finally, our treatments are designed to step in and fix those biological problems to help restore balance and get that person back to health. This whole physiological story brings me to a final thought, something to reflect on that was inspired by the actor Jim Carrey. He once suggested reframing the word depressed as deep rest. It's a powerful idea. What if depression, on some fundamental biological level, is the body's last-ditch effort to demand a shutdown, a forced rest from a life or an identity that has just become physiologically impossible to keep up? Understanding the deep biology behind what's happening to a patient like Jane isn't just an academic exercise. It is the absolute foundation for providing effective, non-judgmental, and truly empathetic care. Thank you for joining me at ANP Live Studio. And please remember, this is for educational purposes. If you or anyone you know is struggling, please reach out for help.